CheckMate 067, we investigated two different immunotherapy medicines individually, ipilimumab or nivolumab, as well as the combination of the two. And we were looking in this study at progression-free and overall survival. These were untreated metastatic melanoma patients, 945 in total, blindedly randomized to one of those three treatment groups.
So a big study, and there were clear differences emerging, weren't there?
There were differences between the three groups. The study was statistically powered to compare nivolumab alone or the combination versus ipilimumab. And both nivolumab and the combination of nivolumab and ipilimumab were statistically significantly better than ipilimumab alone in terms of progression-free survival as well as response rate. Now, in sort of an exploratory analysis, just looking at the numbers descriptively, the combination had both a longer progression-free survival as well as a higher response rate than nivolumab alone.
It seems from a quick look at the figures that you're getting quite good results as long as you have nivolumab as part of the treatment, although ipilimumab is also still obviously very significant. How is this looking to you for the clinical application of all this?
So I think this regimen is very clinically applicable. The other important consideration here is safety. The combination has more side effects than either of the monotherapies. About 55% of patients will have grade 3 or 4 adverse events. Importantly, in this global study, we saw no treatment-related deaths at 137 centers worldwide, which is important because it means that our treatment safety guidelines are working. And that we can apply this therapy in a variety of venues.
Now, have you got any markers that tell you whether you're going to do well on nivolumab rather than ipilimumab?
So we don't have a marker that tells us whether a patient will do better on nivolumab compared with ipilimumab per se. But we do have a marker that was studied in this study, which is tumor cell expression of PD-L1, one of the ligands for PD-1. And we actually prospectively stratified the three treatment groups for PD-L1 expression at a 5% level. And what we saw is that in the primary endpoint of progression-free survival, if a patient's tumor had at least 5% expression of PD-L1, then they actually had the same progression-free survival with nivolumab or the combination, 14 months. Compared to about 3 months for the ipilimumab. Now, if the patient's tumor had less than 5% expression of PD-L1, they actually had a significant increase in the progression-free survival when they expressed the biomarker at this lower level. So this really provides an opportunity for us to use the biomarker in discussions with patients about what is the correct treatment option for them, balancing risk and benefit.
So how do you see this panning out in the near future about which patients should get which drugs and which drugs are likely to be the more popular in the future?
So I think that the PD-1 blocking drugs, because of their better efficacy and safety profile, are going to be considered a potential first choice for patients with metastatic melanoma. Now, whether to offer a patient the combination or a PD-1 blocking medicine alone is still uncertain. We have the availability to offer the combination as part of an expanded access program that is not yet available everywhere. And of course, we await regulatory discussions about the availability of the combination. If a patient is interested in simply the likelihood of response, the response rate, then for the combination, regardless of what the PD-L1 expression status is, the combination yields the highest response rate.
What should busy cancer doctors be thinking about these data right now, do you think?
I think busy cancer doctors need to, first of all, recognize that there are expanding treatment options for this previously difficult to treat cancer, that they can actually now have several different options in terms of standard therapies, but that we believe that this combination is a very, very important consideration if it becomes available commercially.
And what does this imply briefly for the future of advanced melanoma?
I think this implies that we have a therapy that in an unselected group of patients provides 11 plus months of progression-free survival, which is a very significant accomplishment, as pointed out by Dr. Atkins yesterday, because this was a disease that had an overall survival of 7 months, not just 5 years ago. So we have introduced a significant amount of hope into discussions with our patients because of the availability of treatments like this. And that is something that most oncologists should be aware of.
Is there a hint of extended survival plateauing?
So for each of the monotherapies, we know that there is a population of patients that has durable survival. So for ipilimumab, there's about 20% of patients that live 3 years or longer. For nivolumab, we don't have and for pembrolizumab, the other PD-1 blocking medicine, we don't have as many patients out that long. They're simply newer drugs, but it does appear to be a plateau around 30 to 40%. For the combination, the best data we have long-term is from the phase 1 study where we actually had 88% alive at 2 years. That's a smaller group of patients. We will not have the overall survival data for this for quite a while.
So a quick take home for doctors coming out of this is what?
Quick take is that the combination seems to yield the highest likelihood of clinical benefit. It does have more side effects than either nivolumab or ipilimumab. Nivolumab has better efficacy and a better safety profile compared with ipilimumab, and that we await the safety results.